Hi, I want to introduce you to our team, Ashley, Elina and myself, and today we'll be talking about Case 10. This is the case history and samples we received from the wards, and we'll be walking you through how we got the following results. Our patient is an elderly male who has been feeling unwell with a productive cough. He's been held in an isolation ward pending clearance results so he can return to his nursing home. The collected samples came back with 3 main organisms of significance, including Streptococcus pneumoniae and Haemophilus influenzae. As he's over 65, it puts him in a high-risk group for bacterial pneumonia, which we thought his symptoms indicate as a possibility. The presence of MRSA in the blood culture also gave us initial cause for concern, especially considering the chance of sepsis and the spread to other residents within his nursing home. As the patient had serious symptoms, empirical therapy should have been provided on the initial day of contact by the doctor via IV. For example, a third-generation cephalosporin and macrolide until we get further tests back. These organisms can affect anyone, but those who are weakened in some way are at higher risk. This includes age, low immune system, pre-existing illnesses, poor nutrition, or increased exposure from hospital-type settings. MRSA especially is common among people who are in hospitals or nursing homes like our patient. Bacterial pneumonia occurs when the alveoli of the lungs become inflamed. Our patient has 2 of the most common bacteria that cause pneumonia, which work their way into the lungs and then multiply, potentially causing life-threatening complications by interfering with gas exchange. One prevalent classification of bacterial pneumonia is community-acquired, where the patient has not recently been hospitalised. However, considering our patient is living in a nursing home, he is constantly in contact with healthcare workers, and it is most likely he has a form of hospital-acquired pneumonia. Likewise, the constant contact with healthcare workers may have facilitated MRSA transmission. MRSA is genetically distinct from other strains of Staphylococcus aureus and resistant to common antibiotics. It normally lives in the skin, nose and mouth of people without causing any harm to the individual. However, it can be life-threatening if it gets into the body. As the patient is in hospital and an aged care facility, it needed to be ascertained if he is an MRSA carrier. So now we're going to talk you through our laboratory workflow. The sputum samples received in the laboratory were not contaminated with epithelial cells or saliva, as they had less than 25 cells. Care was taken to make sure the patient's mouth was rinsed, dentures removed, and he was directed to cough up a deep sputum sample. The sputum produced was purulent with rusty streaks, which is typical for pneumococcal pneumonia. A gram stain was performed directly on the sputum, which produced a polymicrobial result of gram-positive diplococci. Gram-negative coccobacilli were also present. To plate up the sputum sample, it needed to be homogenized due to the microorganisms being unevenly distributed within the sample. A digestion agent was employed to liquefy the sample, and the DTT method was employed. It was then plated onto McConkey agar, as it is selective for gram-negative organisms such as Klebsiella pneumoniae and Pseudomonas, both common causes of pneumonia. Both aerobic and anaerobic horse blood agar plates were set up to test the growing conditions for gram-positive organisms that could cause lower respiratory tract infections. Finally, chocolate agar with bacitration was incubated in a candle jar to cover fastidious organisms like Haemophilus influenzae, which is common in hospital-acquired pneumonia. For the nasal swabs, HbA was incubated aerobic and anaerobically to test for gram-positive pathogens that can be present in upper respiratory tract infections, including Staphylococcus. For staph, mannitol salt agar was also used. We were given 6 blood bottles, and the assumption is that there are 3 sets of 2, each set to be incubated aerobically and anaerobically, and each set from a different location. In Australia, the normal protocol is 2 sets of 2, so we don't know if the doctor is being overly cautious or if they are highly concerned for our patient. The blood cultures were processed using the BACT/alert system by bioMérieux, which is a carbon dioxide sensitive pH sensor machine. Lastly, subcultures were set up from all 6 of the blood bottles. Our team wanted to cover all bases in terms of this, as any organisms found in the blood would be very serious and need urgent attention. All plates used were for the same reason as the last 2 samples, as our team thought the same organism as both the primary infection and a Staph aureus were possible.
On day 1, the plates that were cultured on day 0 from the direct specimen were examined. The sputum sample that was cultured under McConkey agar produced no growth, which was great because it indicated that we didn't have an Enterobacteriaceae like Klebsiella pneumoniae. On the horse blood agar, aerobic and anaerobic, we found that there was equal growth on both of those plates. The colonies produced a distinctive green zone of clearing, which indicates alpha hemolysis. On the anaerobic plates, we had the production of draftsman colonies. The chocolate agar produced grey-white mucoid colonies. Now, we did set this plate up with the addition of bacitracin to inhibit Streptococcus pneumoniae and other gram-positive Streptococcus and Staph commensals. We did this because we were concerned we did have a fastidious organism like Haemophilus. From these cultures, gram stains were performed on the colonies, and we used the aerobic blood agar plate to perform this gram stain. The organism on that plate produced a gram-positive encapsulated diplococci. So at this point, it told us that we probably have a Streptococcus pneumoniae. The chocolate agar produced a gram-negative coccobacilli that was about 0.5 of a micron. They appeared as very short rods that were tapered at the end, and this organism was non-flagellated, non-motile, but did show some pleomorphism under light microscopy. After this, we set up rapid tests to have a look at some of the metabolic properties of these organisms. If we look at the last two columns, we have the gram-positive diplococci from the sputum sample. This was both catalase and oxidase negative, so that's really telling us that we've got a streptococci species. We did want to set up some further tests to rule out strep viridans, and these tests involved subculturing with the addition of the optochin disc. The gram-negative coccobacilli was catalase and oxidase positive, but indole and urease variable. So that's indicating to us that we have a Haemophilus species. Satellitism test was performed to verify Haemophilus. We used the laboratory Staphylococcus aureus control. It was streaked onto horse blood agar with Haemophilus next to it and incubated in the candle jar to create 5% carbon dioxide. The Haemophilus will only grow in the presence of the heme and NAD. The staph is beta hemolytic, so it will lyse the erythrocytes, releasing NAD and heme, which Haemophilus can utilise for growth. This is why we are seeing colonies of Haemophilus on the blood agar. To confirm Haemophilus influenzae, we also plated the organism on TSA and added an X and V disc. It was then incubated at 37 degrees for 24 hours, and an API-NH was also set up according to the manufacturer's guidelines. Look at the plates for the positive blood bottle culture. One of the bottles produced growth when cultured, which supports the growth we have in 1/6 bottles. The nasal culture produced the same results, indicating the same organism. The blood bottle culture produced no growth on McConkey, but good growth with isolated colonies on chocolate agar. It produced equal growth on anaerobic and aerobic horse blood agar, so this means that we have a facultative anaerobe. Interestingly, the isolate grew very well on the mannitol salt agar. Mannitol salt agar is selective and differential for Staphylococcus aureus. This means selective for the staphylococcal species, but will also differentiate between different members of the genus. The isolates from both the different samples produce bright yellow colonies, and the phenol red indicator has changed the agar from red to yellow. This indicates the fermentation of mannitol. The isolates were both coagulase and DNase positive and novobison sensitive. We were quite happy to diagnose Staphylococcus aureus and get both isolates ready for antibiotic sensitivity testing. The TSA plate was examined and we had growth around the X and V disc, indicating Haemophilus influenzae. The API-20NH was finalised by adding the remaining reagents, reading the individual tests and scoring those results. This produced a numerical number of 3424, which means we have Haemophilus influenzae. The tests for the streptococci isolate were examined on day 2, and we found that there was no growth of the organism around the optochin disc, but there was growth around the bacitracin disc. There was no growth in the saline tube or ascilin, and the ascilin test was negative. The organism showed marked sensitivity to an ampicillin disc on blood agar, so we were able to conclude that it was Streptococcus pneumoniae.
On day 2, we read the results of the antibiotic sensitivity testing, except the blood isolate that was tested later when one of the blood bottles got flagged. All 4 isolates were tested using the UCAS disk diffusion method, which is the preferred standardized method in our laboratory. For vancomycin, we used broth microdilution to determine the MIC breakpoint because disk diffusion would be too unreliable. Antibiotic quality control was also performed following UCAS. The results, as summed up in this table, show that both Staphylococcus isolates were multi-resistant while still sensitive to vancomycin. Streptococcus and Haemophilus were sensitive to all their respective antibiotics. Sensitivity to oxacillin or benzylpenicillin excluded beta-lactam resistance, and therefore relevant beta-lactams with clinical breakpoints can be reported as susceptible.
There is a high chance that the pneumonia in this case is healthcare acquired, which means that some level of antibiotic resistance could be expected. Our sensitivity testing, however, indicates that it's more likely community acquired. The results don't show any need to modify the initial empirical treatment, which involves a beta-lactam such as penicillin, amoxicillin, or cephalosporin, often combined with macrolide, which are proven to reduce inflammatory response. Depending on the severity of the infection, a fluoroquinolone can be used instead, either alone or in combination with one of the two. It's important to note that fluoroquinolones and dual therapy aren't recommended as the first choice for low-risk or non-severe community-acquired pneumonia. Being broad-spectrum, they may promote multi-drug resistance. Fluoroquinolones are also associated with some more serious side effects. In this case, these therapies can be used because the patient can be considered of high risk. Although the patient is colonized by MRSA, he is not necessarily infected by it. It shouldn't be treated unless it's confirmed to cause an infection, since antibiotics like vancomycin should be specifically reserved for MRSA. The nasal MRSA is most likely a sign of hospital-acquired carriage, whereas the isolate in blood is very concerning as it could be an invasive infection and life-threatening. We need to investigate if this bacteremia has developed in septicemia. MRSA septicemia has substantial mortality. The clinical relevance of the positive blood culture is unclear at this point and has to be investigated for contamination by culturing a new set of blood samples. We can suspect contamination because only one bottle was positive and not until the 5th day. Also, the organism found in the blood is different to the organism from the primary site. Then again, the fact that the isolate was MRSA and not a skin commensal could indicate true septicemia. MRSA carriage in the nose also supports this. The patient is more prone to infection by MRSA as his immune system is decreased by pneumonia. The cause of SAB could be undiagnosed endocarditis due to advanced age. We don't have enough clinical data, such as recent infections, antibiotic treatment, any operations, or previous diagnosis that would help assessing the likelihood of septicemia. The doctor should look for any signs of sepsis, which include increased heart and respiratory rate, low blood pressure, and GCS score below 15. So, in conclusion, this patient is suffering from polymicrobial pneumonia that's caused by Streptococcus pneumoniae and Haemophilus influenza. The possible MRSA septicemia has to be investigated before he can return to nursing home so he doesn't compromise the other residents. If the second round of blood bottles turns out positive, vancomycin can be added to therapy. It's recommended that he gets vaccinated for pneumococcus. There's no effective vaccine for non-typable Haemophilus influenza, but vaccination against type B is recommended to prevent other infections in future. So, on behalf of our team, thank you for your attention.